Assalamu alaikum and good morning everyone. This is Dr. Roshana Mahmood working as Indoor Medical Officer, Department of ICU. Today, 12 July, we will be hosting our weekly seminar. At first, we would like to thank our Honorable Director Sir, respected teachers, my dear colleagues and beloved intern doctors for their presence. Welcome you all to our Today's topics is anesthetic consideration for cardiac patient undergoing non-cardiac surgery. Our speaker, Dr. Proloy Ghos, Indoor Medical Officer, Anesthesia Department of CBMCB. Chairperson is our Honorable Associated Professor Dr. M.D. Abul Kalam Azad Sir, Head of the Anesthesia Department. Co-chairperson is Dr. Muhammad Ali Siddiqui Sir, Associated Professor of Anesthesia Department, CBMCB. And resource person is Dr. Lipun Kanti Bhumik Sir, Associated Professor and in charge of ICU Department, CBMCHB. Now I would like to invite our Honorable Chairperson to take his seat on dais and conduct rest of the session. Thank you.
Thank you, Dr. Shumi, Medical Officer ICU. সামনে উপস্থিত সম্মানিত পরিচালক স্যার, সেমিনার চেয়ারম্যান স্যার, উপবিষ্ট আমাদের বিভিন্ন বিভাগীয় প্রধান স্যার, ম্যাডাম এবং সহকর্মীবৃন্দ, ইন্টার্ন চিকিৎসকবৃন্দ, সবাইকে স্বাগত জানাচ্ছি আজকের এই সেমিনারে। তার আগে আমি সেমিনারে আমাদের আজকে চেয়ারম্যান ডক্টর মোহাম্মদ আলী সিদ্দিকী স্যার, অ্যাসোসিয়েট প্রফেসর স্যারকে ডায়াসে আসার জন্য অনুরোধ করছি এবং রিসোর্স পার্সন ডক্টর লিপন কান্তি ভৌমিক, অ্যাসোসিয়েট প্রফেসর ICU, ডায়াসে আসার জন্য আহ্বান জানাচ্ছি। আজকে আমাদের যে টপিকস, আসলে আমাদের অ্যানাস্থেসিয়া এবং রোগীর জন্য খুবই গুরুত্বপূর্ণ একটা টপিকস, যেটা আমরা সাধারণত অ্যানাস্থেসিয়া দিয়ে অনেক সময় রোগীর ভালো করতে গিয়ে আমরা রোগীর লাইফ রিস্কে ফেলে দিই। সো আমাদের আজকের অ্যানাস্থেসিয়ার যে স্পিকার ডক্টর প্রলয় ঘোষ প্রেজেন্ট করবে অ্যানাস্থেটিক কনসিডারেশন ফর কার্ডিয়াক পেশেন্ট আন্ডারগোয়িং নন কার্ডিয়াক সার্জারি। প্রলয় আমাদের CBMCর এক্স স্টুডেন্ট এবং ময়মনসিংহ মেডিকেল কলেজ থেকে সে পোস্ট গ্রাজুয়েট করেছে। সে এখন ইন্ডোর মেডিকেল অফিসার হিসেবে কর্মরত আছে। আমি ডক্টর প্রলয়কে তার প্রেজেন্টেশন করার জন্য অনুরোধ করছি। ডক্টর প্রলয় ঘোষ।
Thank you, sir. Good morning and welcome to all on behalf of our Anesthesiology and Intensive Care Unit. Today's our topic is anesthetic consideration for cardiac patients undergoing non-cardiac surgery. Now, with the permission of our chairperson, I would like to start our today's session. Introduction. Stress due to surgery leads to an increase in cardiac output, which can be achieved easily by normal patient, but which results in substantial morbidity and mortality in those with cardiac disease. Most suitable anesthesia can be given by understanding different cardiac disease. The scale with which the anesthesia is selected and delivered is more important than the drugs used. Number of patients with cardiac disease are increasing. Due to the fact that the surgery is being performed on older patients in whom the incidence of coronary artery disease is higher. Secondly, recent advances in diagnostic technology have allowed us to detect coronary artery disease in asymptomatic or mildly symptomatic patients. What should be our approach? Preoperative, pre-anesthetic evaluation, risk stratification and preparation. Intraoperative, smooth induction, smooth recovery and smooth monitoring. Postoperatively, continuous monitoring and vigilance. Pre-anesthetic evaluation, assessment of pre-anesthetic preoperative risk, Goldman cardiac index, risk stratification criterion, Detsky modified approach to Goldman index, NYHA classification, Canadian Cardiovascular Society classification and ASA grading. Medication, continue all anti-anginal, anti-hypertensive, continue all antiarrhythmics, continue beta blockers and statin, continue aspirin, discontinue diuretics, digitalis, oral hypoglycemic and ACE inhibitors. OT preparation, ready emergency cardiovascular drug, IV beta blockers, nitroglycerin, sodium nitroprusides, inotropes, phenylephrine, calcium channel blockers, antiarrhythmics, cardiac equipments, defibrillator, pacemaker, syringe pump. Monitoring, ECG, blood pressure, temperature, pulse oximetry, end-tidal carbon dioxide. Arterial catheter that measures beat-to-beat blood pressure monitoring, arterial blood gas analysis, early detection of hypertension. Laboratory studies, hemoglobin and hematocrits, electrolytes, liver function test, creatinine clearance, osmolarity. Non-invasive monitoring, output monitors, transesophageal Dopplers, thoracic impedance is limited, accuracy is controversial, no information about systemic vascular resistance, measures central venous pressure. Temperature, keep warm, decreasing temperature, shift oxygen dissociation curve to left. Preoperative preparation, angina medication to control it, blood pressure control diastolic less than 95 millimeter of mercury, congestive heart failure treated with diuretics, afterload reduction, bed rest if indicated, control diabetes. Anesthetic techniques, goals of anesthesia, loss of consciousness, amnesia, analgesia, suppression of reflex, both endocrine and autonomic, muscle relaxation. Anesthetic management, anesthetic technique that local anesthesia, regional anesthesia, combined regional and general anesthesia, general anesthesia. Anesthetic management skill more important than technique. Role of local anesthesia. Local anesthesia should be appropriate with IV sedation. Large doses of anesthetics should be avoided, monitored with ECG, blood pressure and pulse oximeter, supplemental oxygen therapy. Regular verbal contact with patient are important. Regional anesthesia. Intraoperative adverse cardiac event do not differ when general or regional anesthesia is used. Certain procedures have shown better outcome under regional anesthesia. Fracture neck of femur under spinal anesthesia, it's less 25% mortality after GA. Patient with prior MI undergoing transurethral resection of prostate had less than 1% reinfection rate after spinal versus 2 to 8% after GA. Regional anesthesia, loss of sympathetic efferent tone, rapid hemodynamic deterioration. Contraindication, in severe aortic stenosis or hypertrophic obstructive cardiomyopathy, in patient with failing heart who is dependent on sympathetic tone, central neuraxial block can precipitate cardiac arrest. Combined regional and general anesthesia requires a lot of experience on the part of anesthesiologist. Example, for lower abdominal surgery, a combination of lumbar epidural analgesia and general anesthesia can be considered when long surgical procedure, large blood loss, or marked hypothermia is anticipated. A combination of thoracic epidural and general anesthesia can be used for upper abdominal, thoracic, and major vascular surgery. The main advantages of epidural blockade: superior postoperative analgesia and less diminution of vital capacity. Epidural analgesia, by suppressing pain, improves transmural distribution of regional myocardial blood flow, thus minimizing myocardial ischemia. Anesthesia, most common anesthetic technique used for cardiac patient undergoing non-cardiac surgery. Avoid sympathetictomy, risks with intubation, sympathetic stimulation, hypoxia, increased catecholamine, loss of subjective monitor, ischemia. General anesthesia, pre-anesthetic medication, integral part of anesthetic practice, particularly in patients with coronary artery disease and hypertension. Benzodiazepine, reduce anxiety, hemodynamic stability, extended duration of action, potential for hypoxia. Intravenous narcotic, fentanyl, effective control of catecholamine, respiratory depression, prolonged ventilation. Opioid, advantages: excellent analgesia, hemodynamic stability, blunt reflexes. Disadvantage may not block hemodynamic and hormonal response in patient with good left ventricular function, do not ensure amnesia, chest wall rigidity, respiratory depression. Induction agent. Avoid ketamine as it is produced hypertension and tachycardia. Etomidate, painful to inject but more cardiovascular stability. Barbiturate, direct depressant, extended duration of activity, smaller doses, 1 to 2 milligram per kg. Laryngoscopy and intubation. Adequate depth of anesthesia should be ensured prior to intubation. Fentanyl, 5 to 8 microgram per kg, can be given to blunt the sympathetic response to laryngoscopy and intubation. Lidocaine, blunt effect of intubation, 1.5 to 2 milligram per kg, 4 to 6 minutes prior to intubation. Ismolol, IV, 0.5 to 1 milligram per kg, 90 seconds before intubation. Muscle relaxant, succinylcholine is notorious as it is producing arrhythmia. Avoid pancuronium. Vacuronium provides minimum hemodynamic alteration. Doxycycline, cardiovascular stable. Rocuronium should be considered during rapid sequence induction technique. Avoid histamine releasing drugs. Atracurium, mevacurium, which leads to hypertension and tachycardia. Nitrous oxide, increased peripheral vascular resistance, depression of myocardial contractility, mild increase in systemic vascular resistance, air expansion, constrict coronary arteries, aggravates myocardial ischemia. Thus, high FiO2 recommended. Maintain saturation at 95 to 100%. Inhalational agent. Advantages. Myocardial oxygen balance altered favorably by reduction in contractility and afterload. Easily titratable. Can be administered via cardiopulmonary bypass machine. Rapidly eliminated. Disadvantages. Significant hemodynamic variability, may cause tachycardia, possibility of coronary steal syndrome. Inhalational agent, depress myocardium, cause arterial and venous dilatation and decrease sympathetic nervous activity, decrease in blood pressure and cardiac output, thus decrease in myocardial oxygen consumption. Intraoperative predictors, choice of anesthetics. No significant hypotension, no significant tachycardia. Site of surgery, thoracic and upper abdominal surgery increases 2 to 3% risk than extremity procedure. Duration of anesthetics, more than 3 hours, increased risk of morbidity and mortality. Emergency surgery, 2 to 5% greater risk. Cardioactive drugs, nitroglycerin, ismolol, labetalol, clonidine, and nifedipine. Coronary artery disease, major goal, balance supply and demand. Primary determinants of myocardial oxygen demand, wall tension and contractility, factor modifying coronary blood flow, diastolic times, perfusion pressure, coronary vascular tone, intraluminal obstruction. Hemodynamic goals for the patient with coronary artery disease. Prelude, keep the heart small, decrease wall tension, increase perfusion pressure. Afterload, maintain hypertension better than hypotension. Contractility, depression is beneficial. When left ventricular function is adequate, heart rate slow, rhythm usually sinus. Heart failure, inability of the heart to pump enough blood to match tissue requirement. Commonest cause ischemic heart disease, others hypertension, valvular heart disease, and cardiomyopathies. Note that with an increase in contractility, there is a greater cardiac output for some ventricular and diastolic volume. Drug treatment may include angiotensin converting enzyme inhibitors, diuretics, and nitrate. Echocardiogram to assess ejection fraction values of less than 30% equate to severe heart failure. Anesthetic consideration, prelude can be reduced with diuretics and nitrate, and both central venous and pulmonary artery pressure can be monitored. Transesophageal echocardiography, if available, is a useful tool to visualize overall cardiac performance. Maintenance of myocardial contractility, in particular ionotropes, may be needed to oppose the cardiodepressant action of anesthetic agent. Valvular heart disease, aortic stenosis, aortic insufficiency, mitral regurgitation. Mitral stenosis characterized by normal ventricular function, obstruction to left atrial emptying, decreasing cardiac output. Pulmonary congestion from elevation in the left atrial leads to pulmonary hypertension and right ventricular hypertrophy over times. Hemodynamic goals in mitral stenosis. Prelude, enough to maintain flow across stenotic valve, so to maintain ventricular filling. Excess fluid may cause pulmonary edema. Here the heart rate keeps low to allow time for ventricular filling, avoid sinus tachycardia. Rhythm of an atrial fibrillation, control ventricular response. Thus the epidural preferred over spinal, phenylephrine preferred over ephedrine. Mitral regurgitation, characterized by chronic volume overload, may mark the sign of impaired ventricular function. Hemodynamic goal for the patient with mitral regurgitation. Preload maintain or slightly increase, and elevated preload may increase in regurgitated flow. Low preload may cause inadequate cardiac output. After load decreases are beneficial, increase augment regurgitated flow. Heart rate maintain or increase, avoid bradycardia which worsen regurgitated flow. Rhythm atrial fibrillation is occasionally a problem. Both spinal and epidural well tolerated but avoid bradycardia. Aortic stenosis, obstruction to left ventricle outflow, intraventricular systolic pressure and alteration increase, concentric hypertrophy. Hemodynamic goals for the patient with aortic stenosis. Preload full, adequate intravascular volume to fill, maintain BP. After load already elevated, relatively fixed. Coronary perfusion pressure must be maintained. Contractility is usually not a problem. Ionotropes are used in induction in end stage aortic stenosis with hypotension. Watch out for vasodilatation. Treat hypotension with phenylephrine. Rate not too slow, not too fast. Rhythm sinus. Spinal and epidural contraindicated in severe aortic stenosis and high risk for myocardial ischemia. Endocarditis prophylaxis. Consider prophylaxis for all patients with valvular lesion. Hypertension. Anesthesia consideration. Hypertension defined as a diastolic blood pressure more than 90 mm of mercury or systolic blood pressure more than 140 mm of mercury in adult is the most common of all the cardiovascular disease. Most patients under adequate control preoperatively and their medication should be continued till the day of surgery. Poorly controlled or uncontrolled hypertensive are at risk for perioperative complications such as ischemia, myocardial infarction, arrhythmia, and cerebrovascular accident. In mild hypertensive patient, a single dose of long-acting beta blocker may reduce the risk of myocardial ischemia during stressful period. However, in patients with moderate to severe hypertension, cardiology consultation should be obtained and blood pressure brought under control prior to elective surgery. However, the patient who has already received a stent and requires non-cardiac surgery. Drug-eluting stent-related issues, stent thrombosis, both aspirin and clopidogrel, hemorrhage, both control should be aspirin and clopidogrel. Joint advisory recommendation and non-cardiac surgery. Consider bare metal stent in patient require percutaneous intervention and likely to require invasive or surgical procedure within next 12 months. Educate the patient prior to discharge, risks of premature antiplatelet discontinuation. Instruct patient to contact treating cardiologist before antiplatelet discontinuation. Healthcare providers who perform surgical or invasive procedure must be made aware of catastrophic risk of premature antiplatelet discontinuation. Providers who perform surgical or invasive procedure must be made aware of catastrophic risk of premature antiplatelet discontinuation and should contact with treating cardiologist to discuss optimal management strategy. For patients with drug-eluting stent who are to undergo procedure that mandate discontinuation of clopidogrel and continue aspirin if at all possible and restart clopidogrel as soon as possible. No evidence for bridging therapy with antithrombin, warfarin, or glycoprotein 2B3A agent. Postoperative predictors. Ischemia does occurs most commonly in postoperative period, persist for 48 hours or longer following non-cardiac surgery. Predictor value is unknown. Postoperative management. Maintain analgesia, balance supply and demand, supplemental oxygen, continue monitoring into postoperative period, early transfusion, test only if likely to influence treatment, preoperative coronary vascularization if independently indicated, selective use of beta blockers, be aware of premature antiplatelet discontinuation in patient with PTCA stent, continue beta blocker, aspirin and statin. Patient with cardiac disease present for anesthesia every day since their perioperative courses are associated with greater morbidity and mortality. It is important to provide a hemodynamically stable anesthesia. This requires knowledge of the pathophysiology of the disease and of the drugs and procedures and their effect on the patient. Thank you.